you for your introduction. I'm Chang Kim from Severance Cardiovascular Hospital. It's an honor to have opportunity to present my case at APCIS 2022. My case is stent migration rescue during percutaneous pulmonary valve implantation during using two balloons. Patient is 16-year-old male with TOF. He had planned PPVI due to prostatic valve degeneration with stent regurgitation. He had TOF repair and reduced TOF repair at age of 1, and pulmonary valve replacement with Carpentier Edward tissue valve 25 mm at age of 9. He had functional class of NIA class 2, and chest X-ray shows cardiomegaly. ECG shows sinus rhythm with first-degree AV block with RBBB pattern. Heart rate was 68 BPM, and QRS duration was 172 milliseconds. Pre-procedural TT showed prostatic valve stenosis with peak 60 mm mercury and mean pressures 37 mm mercury with moderate prostatic valve regurgitation. TR was grade 2. RV-EDV index was in MRI was 185, and PA regurgitation fraction was 16%. PPVI test with ZMAT 25 mm balloon shows no coronary artery compression and need pre-stent implantation due to different axis of prostatic valve and RVOT. We prepared pre-stent Parmat's P4014 stent mounted on ZMAT 25 mm balloon. As you show in this video, only proximal balloon burst and Parmat's stents migrated to the distal PA. So what should we do in this situation? First, we can think about inserting migrated stent on RPA, but it has a strong radial force and it can make vessel damage, and also it has a risk of thrombosis. If it can be, the retrieving the migrated stent is the best option. There are several ways to take out this migrated stent. Loop snare or guide wire twirling technique or small balloon technique. But loop snaring or guide wiring technique is difficult in this case because of proximal stents are flared. Small balloon technique, which use small profile balloon, can be feasible in this case, so we selected this strategy. Refer to surgery is the last choice. So first, we secure the central lumen of the migrated stent. Using Lunderquist and Millin's long sheets, we secure the central lumen of the stent and cross the stent with the small profile balloon. We selected Armada 12 mm balloon. And second, we insert two balloons side by side in the stent. Slightly ballooning Armada 12 balloon to stretch the stent a bit, and insert ZMAT 25 mm balloon side by side. And distal balloon inflation and pullback. We inflate and pull back Armada 12 mm balloon distal to stent and try to make the stent move backward. But it's not moved backward as much as we expected. The problem is that the MPA axis and the retrieving force vectors were nearly perpendicular, like shows in the image. So we need to rotate the balloon retrieving vector counterclockwise. So by pushing right side balloon and by pulling the left side balloon, we rotate the force vector to the clockwise. And after the rotating the force vector, we inflate and pull back the CMED 25 millimeter balloon and retrieve the stent to the utmost position. We implant stent just above the prosthetic valve and implant melody valve 22 millimeter inside the prosthetic valve. Melody valve was successfully implanted. There was no more PI, and RVOTO was relieved. There was no paravalvular leakage. He has been followed up for 3 years. The recent echo shows no prosthetic valve stenosis and no valve regurgitation, and TR was reduced. RV-EDV index in MRI is decreased to 129, and PA regurgitation fraction to 3.6%. CT and fluoroscopy shows the well-implanted melody valve without fracture. So lesson learned, we have to avoid stent migration, and to avoid stent migration, be cautious. We need the careful and delicate mounting the stent on the balloon catheter, and be prepared. There is a better option, balloon catheter, and be alert. We need the meticulous control of balloon inflation and stretching the stent. Thank you for listening.
Thank you for your interesting case. Is there any comment and question? Yeah, Dr. Ming-Tai Lin. Unmute, please.
Sorry, the 3 times mistake. Sorry. Thank you for interesting and a nice presentation. And you have the same case again. Do you consider use half inflation technique to deploy the stent distal part first, and then if it's stable, you can pull back the outer sheath, the delivery sheath, then inflate the remaining part of the stent?
Excuse me, I didn't understand your question. I'm sorry.
Yeah, I mean, when we deploy stent, there is one technique which is so-called half inflation. That is, when you want to deploy a stent, you always have a shuttle sheath or delivery sheath at the position you want to deploy. And when you advance your stent into the tucky position, the half inflation means you just advance the distal half of the stent out of the sheath and inflate and then inflate that part. When you make sure that part is okay, then you pull back the outer sheath, then inflate the proximal part of the stent. The mechanism a little bit like a BIB balloon, but sometimes if you don't have a BIB balloon, you can use this technique.
Chang, can I answer instead of you?
Yeah, it's
I'm
it's
responsible
difficult question for me, I think.
So what Dr. Ming-Tai Lin explained is a technique to secure the position of a stent. If we have a big balloon in balloon, then it is the best way to securely implant the stent on the correct position. But if we don't have big balloon, the balloon may milk or the slide, or there's so many problem may happen. So Ming-Tai explained the exposed half of the balloon stent complex out of the sheath, then inflate. Then the inflated balloon and stent, the complex is exposed only in the distal half. Then if you are sure that the position of the stent is correct, then you pull back the sheath and expose the whole part, and then you can get the correct position of the stent. It is maybe Ming-Tai, if the memory is correct, it is developed by Dr. Lee Benson, right?
Yes.
Yeah, Lee Benson technique, yeah. So, of course, but we were so confident we have a lot of IVOT stent cases, but so we didn't expect this kind of the complication. And also, when I saw that the balloon is sliding proximally, then the assistant deflate the balloon, so the distal migration occurred. So the retrieval technique or the distal parking technique, the decision should be depends on the case-by-case situation. So thank you for the Ming-Tai, for the nice comment and the nice question. Yeah. Warakan?
Yes. May I miss the very first part of your talk, but the indication of putting the stent before melody valve is to secure the landing zone. Am I correct?
No. The early degeneration of the valve may be the one of the cause, may be the angled bioprosthetic valve, angulated the bioprosthetic valve. If you put the stent, especially long stent, it may correct the oblique angulation of the bioprosthetic valve and make a better landing zone for the melody valve. So it is a very well recognized phenomenon, and we have very successful case, a couple of successful cases before this case. So we wanted to implant the long stent to correct the oblique angulation of a bioprosthetic valve inside the IVP.
Previously implanted, the valve process is to conform more to the anatomy.
Exactly.
I see. Right. The reason I'm asking, because if I understand correctly, now if there's a cage, that can be preventing for the melody valve stent fracture. That's one thing. And second thing, if somehow you are worried on that, stent fracture, you can mount stent in the melody valve and then just simultaneously implant it all together at the same time. So that's also the possibility. I'm not sure whether it's applicable for this case or not, but now I understand. Thank you.
But in ensemble system, with the melody valve itself, it is quite tight.
Okay.
And adding one more stent may give maybe not go inside the ensemble system. So you may use another delivery stem than the ensemble system.
Yes,
yeah.
Probably like dry seal or whatever,
Yeah.
which is bigger and longer.
And thank you.
Thank you.